Great. Okay. Welcome, everyone. Welcome to another Pell's lecture. Today we have the amazing Elissa Kennedy Smith, who is a senior emergency physician. She has rich experience in Victoria and New South Wales, and her kind of subspecialty interests include early pregnancy care in the ED and point of care ultrasound. She has a DDU and she's a former chair of the ASIM Emergency Department Ultrasound Committee. So I'll hand over to Elissa to tell us a bit about herself and tell us a bit about abdominal pathology with point of care ultrasound.
Thanks very much, Ethan, and thanks for asking me along. So yes, I'm a very senior emergency physician, clearly, who has worked, yes, in both New South Wales and numerous hospitals in both New South Wales and Victoria. But I'm down in Victoria at Sandringham Hospital is my main emergency department, and I'm also ultrasound lead for emergency medicine at Alfred Health. And I work at the women's in their early pregnancy assessment clinic and also do emergency telehealth. So that's kind of me. I've been obsessed by ultrasound ever since I realised we could actually use it and stop guessing about, whether or not we could hear a murmur or whether or not we could had a positive Murphy's. And finally puddled along for years doing course after course before realizing I was only going to get better if I actually did a qualification. So I started with CCPUs and then wanted to be able to do it all. So went on to do my DDU and finished that in 2017. So that's a little bit about me. So I'm going to be talking to you about the things that I use point of care ultrasound for when people come in with belly pain, in particular looking at the bowel tonight. So we'll fire away. Oh, nope, got to use this. That's right. So how do I get interested in bowel ultrasound? I suppose really there was as soon as I diagnosed my first appendicitis. I remember my first appendicitis, like I remember my first lung point, like I remember my first free fluid. Really, I can remember the exact cubicle, and I can remember even almost what the patient looked like, and it was quite interesting because it was a handover patient, and the person handing over to me thought that they likely didn't have much going on, and I felt this patient's belly and thought, no, she's really tender in her riff. And I do a lot of obviously looking at ovaries because of my early pregnancy work, and I thought I'm just at least going to rule out something ovarian. And her appendix popped up and met me, and I was so excited. I remember, and I had to contain my excitement because I was about to tell this woman she had appendicitis, but I didn't want to look too excited about that. But it was a perfect little appendix, and it showed itself really clearly, and I was able to completely prove that diagnosis by following it all the way back to its cecum and following it to its blind end and measuring it and doing all the right things. But as soon as I diagnosed that one, I hadn't looked back and I realized that you can look at a lot of other things. So yes, as I said, emergency physician, but also ultrasound tragic for numerous years, and now officially as a DDU as sort of an emergency sonologist as well. As Ethan already said, I've got a special interest in early pregnancy, but have gone on to really kind of have bowel as another area. To be honest, I just love all areas of point of care ultrasound that are relevant to the emergency department, but I do like those two especially. Yes, there is a lot we can actually look at that goes beyond appendicitis with respect to bowel, and I use it on a regular basis. I love belly pains that come in to the ED, and I try and pick them up as quickly as I can because most of the time I'm going to be able to use the ultrasound on them. So ultrasound for bowel, it's full of gas, and we all know that gas is the enemy of the ultrasound beam. So why am I looking at bowel? But just like the explosion of this head, gas can be moved on with encouragement. And, graded compression is the term that we use to move bowel out of our way. And you can do a number of other things to sort of assist with that. If it is diseased bowel, often you can get a fair bit of free fluid, a fair bit of fluid within the bowel that can demonstrate the bowel wall more clearly, and you might have some surrounding free fluid if the bowel's actually got to the point of being a bit leaky, or if there has been a perforation associated with that. Other things you might see is, thickened bowel walls. Might see either reduced or hyperperistalsis, dilated bowel, perienteric inflamed fat, which is echogenic. And you might even see some hyperemia of the bowel wall and also a hyperemia of that perienteric inflamed fat. You really need to get used to looking at what normal bowel is. Now, a lot of the time, normal bowel wall you won't actually see because it's so thin. But it's like when I'm telling anyone when they're even starting just with EFAST, it's really important just to actually start looking around, not just at the views that you want to get, the Morrison's pouch, but just start noticing what normal of everything looks like. Because as soon as you kind of think, well, that's obviously bowel because I can see there's some peristalsis and things moving on. I can't really see the bowel wall. If you really start to notice what normal looks like, as soon as something's abnormal, it sticks out like the proverbial. So, sorry, dog barking in the background. Hang on a minute. Just let me try and stop.
That's all
Sorry,
right.
guys.
We can't hear the dog anyway,
Oh,
so
you
it's all
can't hear the
good.
dog? Oh,
Yeah.
that's great. Oof. Okay. I was about to yell and try and get my son to. Anyway, we'll ignore the dog if you can't hear the dog. That's great. Um, okay. So yes, but not only what the normal bowel looks like, but also what the normal gut wall signature looks like. So that's important. Okay, the dog. I can't believe you can't hear the dog barking. It's really loud. Obviously, these are better than I thought. So in terms of the gut wall signature, we're looking at the 5 layers going from the inside of the bowel wall to the outside. It's sort of hyperechoic, hypoechoic, hyperechoic, hypoechoic, hyperechoic. So it's nice and easy to remember. The first hyperechoic layer is really the interface between the gut lumen and the mucosa. So this is really what we're looking at here. And it's probably a little bit that you've actually got your 2 mucosal layers against one another there. Then the next layer we've got is our hyperechoic mucosa. So this is kind of your 2 layers of mucus probably up against one another, maybe with a little bit of bowel contents in there. And then the actual mucosa is hypoechoic. The submucosa is hyperechoic. The muscularis is hypoechoic, and then the serosa, which you kind of just making out on the, and I'll show you on the next one, is also hyperechoic. So getting used to what that looks like, and that's a nicer one there that you can once again say we've got the bowel contents, and then this interface between the mucosa and the bowel contents being hyperechoic, the mucosa, submucosa, muscularis, and then the serosa on the outside. So I usually start, it depends on what diagnosis I'm suspecting, as to exactly how I'll start my scan. But mostly in adults, I'm starting with a curvilinear probe to get more of an overview. And then depending on what I'm suspecting and what I've seen, I might move to the linear probe. Obviously, if they're a bigger patient with a bit more subcutaneous tissue between me and the peritoneal surface, I might just stick with a curvilinear probe. And in peds, once again, I usually still start, unless they're really little, I'll still start with curvilinear to sort of have a bit of a look, right upper quadrant, left upper quadrant. But then, if it's a small baby, I'll just, or an infant, I'll generally start with a linear probe. You can use a lawnmower technique, but once again, it depends on what I'm looking for. If I'm thinking that someone has bowel obstruction, I'll probably start. I actually start now. I'll go through how I do small bowel. If I'm not really sure what's going on, I'm probably more likely to do a lawnmower technique, but I might also just start with right upper quadrant, left upper quadrant, looking for free fluid, pelvic view, looking for free fluid. So more of it, almost an EFAST, and then moving more to the point of maximal tenderness. But yeah, so it depends on what I'm thinking about from having, my history and examination as to exactly my approach. But the graded compression is the most important thing. And that's really, trying to move normal bowel out of the way, trying to move gas out of the way so that you can see, what's going on. And if someone's got tummy pain, you really need to make sure that you're giving them adequate analgesia. So, I get a lot of people saying to me, "Oh, you find the appendix so much more than the sonographers." The reason is we often send these patients around to the poor sonographers under analgesed, and they try and do graded compression, and the patient doesn't tolerate it. So if someone's not tolerating my graded compression, I just go and get some more morphine and give them more morphine and wait for another 5 minutes, and then I can do more graded compression to try and, actually see what I need. So really think about making sure that you adequately analgesing these patients will really help. And that's just that mowing the lawn type, looking for any abnormalities of the bowel. So yes, appendicitis will always be my first love. I love scanning for appendicitis. I'm probably up to about my, I don't know, I reckon 200th or 300th diagnosis of appendicitis, whereas I've probably only proven a completely normal appendix maybe 15 times. So that means I've followed the appendix from its origin and the cecum all the way to its tip, and proven that is completely normal, because a normal appendix is a slippery little sucker, and it's thin, and every time you do graded compression, it disappears. And so being able to follow that appendix the whole way actually can be quite time consuming, and who's got time to do that in the ED? So if I'm not seeing any secondary signs or anything, and I kind of have seen what I'm pretty sure is the appendix at least coming out of the cecum, or its blind tip, but lost it along the way a little bit, and there's no secondary signs, I'm usually pretty happy to say that, it's very unlikely. Often it's the most difficult part is following it all the way to that, blind end. So yes, appendicitis is a very nice case. Obviously mildly dilated with some good going echogenic fat deep to the appendix, and you can see that blind end. And you can still sort of see those layers in the wall of the appendix, that gut wall signature. But clearly a person with not much subcutaneous tissue, which really helps. I often get asked to scan people, and they're 150 kilos, and I'm not bothering to scan them for appendicitis. It's just not, the point of care machines aren't that great for that situation. And really, those people need a CT, because they're far better designed for CT than they are for an ultrasound. So we have known that appendicitis is ultrasound is very useful for appendicitis for a very long time. We've always said it makes sense. Its specificity is better than its sensitivity, because if you see a big inflamed appendix, they've got appendicitis, as long as you have, followed it at least to its, ideally to both its origin and to its blind end. But really more recent studies, especially in the pediatric population, show that we're actually getting pretty good at this. And one of the first people I listened to who spoke about appendicitis years ago, and they said, look, if you gave med students who had all day a probe and taught them how to do it, they'd probably find just about everyone's appendix, other than maybe the completely retrocecal appendix, because, you will be able to follow it. It just is very time consuming, especially when it's a normal appendix and it's a slippery little sucker. But we can do this. We just have to know the tips and tricks. Of course, it's not going to be as good as CT in every case but in skinny people, it's actually better. I've diagnosed a few appendicitis that the CT scan was done and was reported as normal, because they have hardly any perinephric fat around. So it makes it really hard to see the appendix in those situations. So in skinny people, as long as it's not a completely retrocecal appendix, it actually could be even a little bit better at times. But most people, a CT is still going to be more sensitive. There's a number of studies, of course, that suggest we can do this in the emergency department with pretty good sensitivities and specificities. Obviously, it's probably pretty intense training of people who have already got quite good skills, I'm guessing. I can't remember the exact study. I'm pulling those figures from a talk I gave a little while ago that I haven't re-looked up, but I'm sure there's even more studies these days that show we can do it. And it's just like anything, we get better the more skilled we get. not rocket science. The more tips and tricks we know, the more that we know we have to give adequate analgesia if we really want to be able to see an inflamed appendix. Not surprisingly, if we do this, of course, we can end up with reduced ED length of stays and, of course, reduced CT utilisation. And I'll flatly refuse, because where I'm working at the moment, I haven't got the ability to put my images onto the patient's EMR. Some people still want to get CTs, and if you want to get a CT, you can, but I coach my patients generally to say, if they try and tell you have a CT, no, you can tell them to come and have a look at the images on my machine. I've actually got a way now I can take the pictures and put them on via, what's the app? There's an app that now we can take all of our clinical media on. So I actually take pictures of my stills of my appendix closed classic target sign images that the surgeons want to see, and I'll put it on that way so that at least they can have a look. And that is meaning that a lot more are able to, and in fact, I've even had a few surge regs recently who want to come down and look at my images, which is cool, because they're actually getting quite interested in and maybe doing this themselves, which is also very exciting. So it's really pretest probability comes into it, and I'm getting a good idea from my history examination. Not necessarily bloods in a kid, of course, but probably bloods in an adult, and then using my ultrasound findings to sort of risk stratify. As I said, I've already talked about the curvilinear probe, but I do make sure, especially in adults, you'll be quite surprised. I've had people who are riff pains and they're tender in their riff, and in fact, they've got hydronephrosis and they're a renal colic, which makes no sense, but patients don't always read the books. In females, I'm always looking to see for ovaries, etc. So that's why I really want an overview before I go to the point of, where I think there is maximal tenderness, if I do think maximal tenderness is in the riff. And, often I'll actually just get the patient to say, I'll give them the probe and I'll say, can you put the probe on where you're feeling the most amount of tenderness? And I reckon in a quarter of cases with a bit of graded compression, where they've put the probe, I find the appendix if there's an appendicitis. And then, with a bit more looking around, if it's appendicitis, you're probably going up to about a third. A third need a little bit more encouragement. And then, there's a group that I'm never going to see it, but I've seen some free fluid, and I've seen there's lots of fat stranding around the area, and they're over their cecal pouch, they're really tender, and the cecum looks like it's a little bit abnormal, probably a bit inflamed as well. And I'll say, I think this person's got a retrocecal appendix, and of course they're going to end up with a CT, unfortunately. Unless they're young, of course. And every time I've said something like that, they've turned out to have a retrocecal appendix. You want to, use your landmarks. Iliacs are a great landmark. A lot of the time, the appendix, like it was in that shot just before, draped beautifully over the iliacs. You want to have a look over your psoas and all around the cecum. I'll roll the patient sometimes to see whether or not, I've sometimes seen the tip of the appendix coming out from the lateral aspect, of the sort of cecal pouch. So you can hunt around to see whether or not, you can see some part of the appendix coming out from that retrocecal position. And of course, the terminal ileum is a great landmark to be looking for as well. So we want to prove it's the appendix, ideally by showing that this is my appendix coming out of my cecum here. Can you guys see my my pointer?
Yep, we can.
Oh, that's great. Excellent. So this is cecal wall here, which of course is nice and thin, and you can barely make it out with some contents here in the cecum. And then here is the appendix coming out of the cecum, just there with that lovely gut wall signature. You guys have, oh, there we go. And yes, and even probably coming to, I reckon that might not actually be its blind end. I reckon that's a bit too short. I've probably just obliqued off it and it looks like a blind end, but that's what you have to convince yourself of. That, and often if I'm not completely convinced about a blind end, I'll then go into trans and just watch it disappear. So yes, obviously blind end and non-peristalsing. sit on it for a while and watch it. I've quite a few times gone, oh, this is the appendix, and I watch for a bit and I watch for a bit, and all of a sudden it peristalsis, and it's like, no, it's not. That's actually terminal ileum. Because it is amazing how long some people's appendices can be. So, if I'm sort of following it and then I lose it and it looks really small, but I'm pretty sure it looks like the appendix, and then all of a sudden it moves, it's like, okay, no, obviously I've just lost the end, and it's a terminal ileum that's continuing on, but I've lost it. And which can be very easy to do when you've got lots of, small bowel filled with gas around the area. You can easily lose what you're trying to chase behind a bit of gas-filled bowel that gets in your way because it's just peristalsis into your way. And of course, you want to be looking for that gut wall signature, as you can see, but that can be lost as the appendix becomes more inflamed, which is shown in this next slide. So that's terminal ileum sitting above the appendix, sitting superficial, sorry, to the appendix. And this is the appendix down here. And now you've started to lose that gut wall signature, which can happen as it becomes more inflamed. So the signs of appendicitis is, size is only one aspect. I've seen a completely normal appendix in a tall person that was measuring 8, close to 9 millimeters, and had no other signs of inflammation. So you have to take size into, into perspective of the rest of the symptoms. And certainly we've seen a few where kids have been referred in and they've come in with an appendix of size 6 millimeters, and they're a bigger kid and they've got no other signs of inflammation. So size, you just have to take it into account of what you really think is going on. They say 6, of course, is more sensitive and 7's more specific, but I do think you wouldn't be calling appendicitis unless you have other features just on size alone. So round like this is here rather than oval in appearance, non-compressible and obviously tended to probe pressure when you're pushing on it, when you're doing that graded compression, and this lovely perienteric inflamed fat. And this is almost definitely, you can see the terminal ileum sitting over the top here. Plus or minus a bit of free fluid, plus or minus you might see an appendicolith, and if the conditions of not much soft tissue between you and the area allow, then it can often see beautiful hyperemia of both the appendix as well as some perienteric fat. So here's a nice little example of, you can see the cecum up here giving birth to the appendix here, and then us following that along. Didn't quite get to the blind end. It can be really difficult to show the blind end in longitudinal. Some people's appendices are so wiggly. They go back and forward, and it's almost impossible to show it in completely long because they just go, they look like a wriggle worm. And so sometimes you really just have to demonstrate it like this, kind of going along in trans. But once again, you're getting this beautiful definition because there's not really any subcutaneous fat. It's all just muscle and a little bit of skin. But you can once again just see that, yes, although it's not a huge appendix, it's more round, and you've got this tiny bit of perienteric inflamed fat around it as well. So this is a bit more concerning. That one looks like a pretty uncomplicated appendix, the last one. Whereas this one, we've lost our gut wall signature. We seem to have a little bit of slothing going on within the, oops, hang on a minute. Why is that? Stop moving. No. It's all right. I might just go back and see if we can get it to move again. All right, let's try again. So you can see I'm compressing this. It was painful, no doubt. It's not compressible. And we've also got what looks like a breach in the appendix wall here, and probably, a little bit of free flow. That's probably a collection, really. So the wall doesn't look like it's intact, and also we've lost that gut wall signature with a lot of surrounding echogenic fat as well around that blind end. So I would be reporting that as potentially perforation. Not a huge amount, but certainly probably a more complicated appendicitis. I'll have a good look around and make sure I can't see any larger collections. As I said, that sort of really would be a micro collection, but still definitely a lot more concerning than the last one. So I think that one was, yeah, up, you can see up in that corner, it was 8.4 millimeters. So, but not huge, still got its gut wall signature, but definitely got this echogenic fat around. Not often the fat can be a little bit more impressive deep to the appendix than superficial. But so making sure that you're having a look deep to the appendix, not just in the superficial tissues. And when you've got, you know, very little subcutaneous tissue or fat there, it can light up like a Christmas tree and be very pretty to show that hyperemia. Now this one I know I have to press start on. So while this looks, there we go. So we've got our iliac vessels and Mrs. Me trying to compress the appendix here, which is having none of it. It's nice and, I don't know why, for some reason me going onto that makes it not want to continue to play. Let's start that again. But yeah, so that's a round appendix. You've got, once again, that echogenic fat more off to the right-hand side of the image. But it's, you know, if you weren't paying attention, you could actually mistake that for one of the iliac vessels. But you've got your iliac artery and vein right there in that very non-compressible appendix. And this is just an example of an appendicolith, which, you know, just because you've got an appendicolith doesn't mean you've got appendicitis, but certainly if you've got any of the other features, you know, you're more likely to end up with appendicitis if you do have appendicoliths. So that's shadowing deep to the appendicolith. Okay, so obviously we can only diagnose it if we can see it. But yes, you know, you can have a pretty good gut feel that they've got a retrocecal appendicitis for all those other reasons that I said with other secondary signs. But you can't, it makes it very hard to rule it out if you've not been able to see the appendix at all, which happens to me probably about a third of times. I just can't see the appendix. But I'll once again go back to my risk stratification. You know, how much did I think they really had it? How have they got any other signs there? How tender are they to my probe pressure over that cecum? Because the appendix is going to be hiding behind the cecum if I can't see it. Obviously, if you can't perform adequate graded compression, you can't often then unmask your appendix because you know the patient's not tolerating it. So you know have more analgesia ready and raring to go. So if we do have a lot of complications, if the appendix is really big and there's some perforations, you might not really know what's what. And, you know, you just kind of got to go, well, the history sounds like appendicitis. It's been going for a while. There's some collections in there. But it can be really tricky once it's a bit more complicated. All right, I'll move on to small bowel obstruction. I guess we'll just do questions at the end. So small bowel obstruction really, you know, once again, evidence shows that it's actually pretty good once we know what we're doing. It's got, once again, better specificities than sensitivities, but really good negative and positive like-liquid ratios. So it's dependent on us, how good we are at doing this. It's dependent on the patient. But I think it's a very useful test to help expedite the diagnosis. And of course, when you haven't got a CT in the same building as you, it becomes really useful. So worthwhile learning about, I think. So we're talking about dilated, which is greater than 2.5 to 3 centimeters. Once again, you know, more sensitive 2.5, more specific if you're going greater than 3. And you want to be having that over a loop of kind of really 2 or 3 loops of bowel or greater than 10 centimeters. So when a small bowel obstruction first starts, you really get increased peristaltic to and fro bowel movement or bowel peristalsis. And then often you're getting collapsed bowel distal to the stenotic area or the area where there's, you know, if there's adhesions, etc. But as bowel obstructions continue to progress and the bowel gets more annoyed because it's very unhappy, it can then become really reduced peristaltic movements and actually almost be, like an ileus. And with that, the bowel becomes leaky, and you can also get free fluid between these dilated loops of bowel, as well as the dilated bowel wall, and also the valvular connervantes can become dilated and quite pretty as well. Not for the patient, but certainly can become pretty for us to look at. So the European Federation and Society of Ultrasound in Medicine and Biology, that's what it is, our position statement on how they recommend us doing bowel. And ever since I did the bowel chapter for the latest Cameron book, I actually started doing this as well. I learned something. But yes, starting in the epigastrium, in trans, looking at stomach for if it's dilated and what stomach contents there are, and then really moving to the left mid abdomen to have a look at your jejunum and descending colon, and then right lower quadrant view to assess your ileocecal junction. And if you've got a more widespread small bowel obstruction that you kind of really can't find exactly where there is, and finding that stenotic area or finding where there's, is collapse afterward can be really tricky. That part's not easy, finding the cause. But if you do have a more widespread bowel obstruction, just think about looking for potential hernias, asking the patient if they've noticed any lumps or bumps in their groin. It might be worthwhile having a look for that. So this is kind of what we're talking about. This is obviously a little bit more prolonged bowel obstruction. We haven't got as much hyperperistalsis. It's looking a bit sluggish now. We've got fluid-filled bowel with the Tenga sign, which basically just means free fluid in amongst the bowel loops. And, quite dilated loops of small bowel being, well over 3 centimetres. And this is probably a little bit more active bowel with that sort of to and fro motion going on, probably a little bit of free fluid living between some of the bowel loops there. And then this one I've got 2 in a row, and this is kind of a bit more impressive when it goes all the way back. So that to and fro motion. And that was the same patient as this one, and she actually had a past history years ago of query diagnosis of Crohn's disease. And, she actually had this area of her terminal ileum that really didn't look like it was probably going to do much in terms of peristalsis and things. And it ended up being that was that it all kind of become a lot more chronically stenotic. And she was having trouble getting things through there, which had caused her bowel obstruction. So if you do have lots of gas, especially early on, anteriorly in the obstructed bowel, it makes it a lot more difficult to diagnose because the gas will just get in your way. Obviously, if the patient has lots of pain and is vomiting a lot, that might make it really difficult to scan them. You've got to be careful because infectious viral enteritis can have large amounts of very fluid-filled hyperperistaltic bowel, but it shouldn't really have any of the other features. And normal bowel can actually have some degree of to and fro motion, but it shouldn't be a huge amount. Things should definitely be going generally in one direction with maybe just a little bit every now and then going back. So you need to sort of take all that into account. Once again, that sort of pre-test probability when you're doing these scans. So a few other things that we might see. Diverticulitis. I actually do a fair bit of scanning for diverticulitis these days, especially when the patient already knows that they have the diagnosis, has been diagnosed before on a CT. I've seen a few now, ileitis, cechitis, where I've been scanning looking for appendicitis and have found those 2 diagnoses instead. I'm yet to find a pyloric stenosis or intussusception. despite scanning. I haven't had that many babies that I was actually thinking were true pyloric stenosis, but I have scanned them whenever I've thought of it, and yet I'm yet to find one. And I'm yet to find my first interception, which I'm a bit sad about, but that's good for the kids, but bad for me. If you're scanning bowel, you're going to come across cancers at some point in time as well. So, yes, where I work, obviously, we have very easy access to CT scans, and most patients, I wouldn't. I would do a CT. If I'm thinking of the diagnosis, then they've never had diverticulitis diagnosed. I might have a look if I've got time, if the department's not on its head. But if I really need to know for sure if someone's got diverticulitis, I'm not just going to go on a hunt. If I think that's the likely diagnosis, I'll get them to a CT. But if someone comes in and they think they've got a recurrent episode of diverticulitis that's been made before, then I'll often have a look and I'll decide once again how tender they are, if I get good views, and if their bloods are all not too bad, I generally will then have a conversation with the patient about, I think this is going to be mild to moderate at most. It's been going for a few days, so it's probably appropriate just to put you on antibiotics. We can do a CT scan if you want. But I think, here's the segment of bowel that I think is abnormal. And most patients actually don't want the CT, I found. They're quite happy to, and I suppose you could say, well, if they've got, if you don't think they're going to have complications from it, do you even need to do the scan, ultrasound? But I think it's nice to be able to show a bit of inflamed bowel there and that you don't think has any complications. You've got to understand the limitations. Gas, sometimes we can move it, sometimes we can't move it. And once again, you've got to be careful if there's lots of gas in the way that you're not actually missing, that there is an abscess or a collection that we've missed. And of course, bigger patients are always going to be more difficult because, just the limitations of ultrasound. So diverticulums can look like all sorts of things. I hope my clips aren't going to stop, but as you can see, we've got bowel here with this little diverticulum off to the side. Here, we've got some inflamed perinephric fat around. It's actually quite a thick muscularis. That often happens when you've got diverticulitis and you've had it for a while. So that's often a more chronic change, whereas often you might see more thickened submucosa in the acute setting. It can vary, but if it's often really thick, it means that they probably had diverticulitis for a while. But the inflamed part acutely is almost definitely going to be this part where you've got, this is little inflamed diverticulum with that echogenic fat around it. And then here's another one, which is quite a flat bowel, quite an empty. This is probably descending colon, and they've just got that little inflamed. I think it's probably, I reckon it's probably like a little bit of a fecalith in there rather than just gas. And of course, I've now managed to stop that. So I'm going to try and go back and try that again. And you can see the shadowing deep to it, but really importantly, you can see that echogenic inflamed fat all around that echogenic nodule there. And then you can see how it's arising from that bit of bowel that otherwise looks actually quite normal. So it's really just this diverticulum that's become a bit inflamed. And the rest of the bowel looks okay. And that's just looking at that same one, just showing that it definitely comes from that bit of bowel. As I said, the rest of the bowel doesn't look too inflamed, but you can see that really echogenic fat that is living around that nice, oh no, I've stopped it again. I have no idea why that happens. It's very annoying. I'm just going to do it one more time. And so, yeah, just looking here, you can see really inflamed area of fat around there, which is exactly where the patient was tender. Here's another one. There's an inferior one. You can just see that the bowel looks a little bit thickened around where that diverticulum's coming off. I'm reticent to use my pointer because it'll stop. But you can see that echogenic, here we go, this diverticulum here with that echogenic fat around it. And often, as I said, it is really where that, just that maximal point of tenderness is. And here's just looking at that exact same one, but now with the linear probe, because this lady was quite thin and amenable to changing to a linear probe, and slightly thickened, bowel wall just at that area where that diverticulum was. But you can really make out on this one how you've got that lovely echogenic fat around the inflamed diverticulum. And this is actually one where I thought there was probably a perforation. I haven't shown it here, but this gent had chronic, like he'd had diverticulitis on and off. And so this really thickened muscularis is a really chronic change that happens. But he actually had some more acute changes and inflamed fat further along down. But really, I just wanted to show you how, like you don't see the bowel unless it sticks out like this because it's just got such thickened muscularis there. And that was, this gent had many episodes of diverticulitis over the years. Yes, just quickly, I know we're kind of getting close, so I'll hurry up. But yeah, I thought I was scanning this young man thinking that he was going to be an appendicitis. He really didn't look particularly unwell, but he was very tender. And although I didn't convincingly see his appendix, the predominant thing was that he just had this really inflamed, and you can see it's the submucosa here that's really thickened, so that uh, the lumen, and then you've got your mucosa, and then you've got that really echogenic white submucosa that's thickened, and the muscularis not so much, and the serosa is a bit difficult to appreciate here. This was a little while ago, and I must admit I ended up worrying that I was missing something. So I got him a CT, and it just showed exactly that over that length of bowel. And we ended up, having a chat to gastro, and everyone thought that it was going to just be an infectious one. So we treated him with some antis, and he ended up going to our intestinal bowel ultrasound unit for follow-up about 6 weeks later, and it all returned to normal. And that's just measuring. I'm really just measuring, actually. I've measured that inaccurately. That's just the submucosa I'm measuring, really. I should have gone out a bit further if I'm measuring the whole bowel wall, because this is submucosa, this is muscularis, and this, can't really see the serosa clearly. And just measuring sort of the length, it looked a lot more, and a little bit of free fluid there. It looked a lot more normal when you went more distally. And then similar sort of case. Oh no. Oh, here we go. So similar sort of case here with iliacs in view. And this was turned out to be like a case of terminal ileitis. That was not concerning for a inflammatory bowel disease, just more concerning for an infectious one. But once again, her inflammatory markers weren't particularly impressive. And I ended up going back. I was trying to follow it along, and in fact, it wasn't even terminal ileitis. It was more just a distal segment. Because every time I'd try and follow it actually to her, and you can see here, you've just got this thickened submucosal aspect. And I think it's sort of flipped around, and this was actually some more thickened bowel with a little bit of free fluid. And every time I tried to follow it to the cecum, it'd get a lot thinner. Anyway, ended up once again just treating as an infectious cause, and you can see those kind of few loops of thickened ileum there with our iliacs underneath. So you do see lots of other things, and I think when you're unsure of exactly what's going on, it's probably not unreasonable to get a CT if you can, to back things up. But a lot of the time, all you're doing is treating these as infectious, which could even, they could be viral infectious. It's really just getting that follow-up to make sure they haven't got anything else going on that's a bit more sinister, which we're really lucky at Alfred Health. We've got a great intestinal bowel ultrasound service, which I was lucky enough to go and scan with like a few times, actually. My last one was a sabbatical last year, and yeah, they do a lot of follow-up of these cases, which is fantastic. So pyloric stenosis, thing to remember is pi. It's 3.14. So if you ever see this, the definition is that you've got a muscle width of the pylorus, which is the one wall, which is greater than or equal to 3 millimeters, and the pyloric canal length is greater than 1.4 centimeters. So there's your pi. That you don't see any peristalsis through the pylorus, and you're sort of seeing in trans a sonalucent donut that lives medial to your gallbladder or anterior to your right kidney. Thickened echogenic mucosa within the pylorus, and it's best if you can actually try and get the patient to have a small feed, not so that it's all about to come back up, and get them rolled onto their right lateral position, and using some sucrose as well. But I have done the procedure. I've yet to find one. I wasn't convinced in anyone that I'd actually scanned, but you can see here, this is the stomach, and then you've got that thickened echogenic mucosa within the pylorus, and this is the anterior wall and the posterior wall. And you'd want to do measurements, and as you can see, I've stolen this from someone else because I don't have any of my own pictures, but they just gave them a quick 2-minute feed because they don't want their stomach to be too full, so that then it tries to contract and ends up being vomited out. But just a little feed so that you can actually show the anatomy nice and clearly. And this is one where you've got some measurements once again where I've stolen with the gallbladder living there. You've got your length of you've got your anterior wall, your length of your canal, which meets those criteria. So yes, you're obviously using a linear probe. You might even need like the smaller footprint linear probe a lot of the time, and trying to get those fantastic conditions. Interception also has not been, I've not been lucky finding one. So you've got multiple layers because you've got one bit of bowel. I always get this wrong. The anyway, the bit that goes in and then the bit that's surrounding it. So you've got lots of layers of bowel, concentric rings. You've got the hypoechoic muscle rim with the central echogenicity, which might be mesentery or mucosa or intestinal contents. So in longitudinal, it's sort of called the pseudokidney appearance, and in trans is more of a donut sign. So you can have ileocolic interceptions, which are the ones that cause more issues. You can actually have small bowel interceptions, which are probably more common, we realize, and probably just cause intermittent small episodes of pain that just tends to self-resolve. If you've got a small amount of free fluid, it's not uncommon, but large amounts, of course, are more concerning for, once again, getting leaky bowel because of unhappy bowel. And also, if it's a large amount, you've got to be concerned that there might actually be perforation, and more concerning if you look and find signs of sort of bowel obstruction and loss of the normal ileocecal anatomy. So if things that would favour an ileocolic one is if you've got an AP diameter that's greater than 2 centimetres, or a length of the interception of greater than 3 centimetres, a presence of a hyperechoic core, which is representing sort of the mesenteric fat, and a thicker outer hypoechoic wall, of course, is more concerning once again for that being sort of cecum. If you've got lymph nodes inside the interception, that's more likely to be ileocolic. And obviously the position in the bowel, which is so important when you're looking at bowel, is actually looking at the position because, that'll give you an idea. In saying that, I once found a piece of, a bit of someone's sigmoid colon. They had a saggy sigmoid colon. I found some of their sigmoid colon right up, very close to the right upper quadrant. This was when I was actually scanning in part of my sabbatical, and I was scanning in Italy, and I was following it around. I'm like, I think that this is actually a bit of sigmoid colon. And the guy who was supervising me, yeah, sometimes elderly people have these really saggy sigmoid colons that could end up in all sorts of places. I'm like, okay, I'm not going mad. Anyway, I digress. But generally, if you're looking and you're finding your interceptum in your right lower quadrant or right-sided abdo, that's going to be more likely to be ileocolic as compared to small bowel, which is more likely to be central or the left side of the abdo. And these are some pictures, once again, stolen because I don't have any of my own, which is very sad. But this is your target lesion of the interception. Oh, I should remember this, but I can never remember it. Anyway, the bit on the inside that's been taken into the bit on the outside. And then in long axis, more like a kidney appearance, where this is the bit that's been taken in. and this is the surrounding. And with that size, it'd almost definitely be ileocolic. So this is, your cecum, and this is your ileum. And here we go. Intersusceptions. So I think that's why it gets me, because intersusceptions makes me think it should be the inside part, and then the intersusceptum is the inside part. I'll never remember that as long as I live, I'm sure. And just a couple more pictures. And this is a very pretty one that you can sort of see why they say it looks like a kidney, with your cecum on the outside and your ileum living on the inside there, and more echogenic core. And once again here with that donut sign. So bowel tumors can vary a lot in appearance, and depends on the type of bowel tumor, but even within, the adenocarcinomas are the most common malignant tumor of the GIT, and they can be all sorts of appearances. They can be more look like an apple core because they're sort of infiltrating, or they can be fungating polypoid. So really anything that looks particularly abnormal, that person's going to be getting a CT plus or minus a most likely colonoscopy. Just for one that I found, I was looking at this gent because he came in with melena, and I felt a mass that felt pulsatile. And as you can see where his iliac's there, but he was actually sort of living at the start of this mass was just really where the bifurcation of his aorta was. So, and he was a thinner man. And so the mass felt quite pulsatile. So I actually was looking at him to make sure that he didn't have a AAA. And I found this instead. So I couldn't work out exactly where this, it was quite central, as you can see the iliac separating here in trans below it. So it's quite centrally located. I tried to kind of match it up thinking it might be cecal, but turned out this is a classic appearance, which I think I didn't know until, well, I didn't know until afterwards because I was still studying for my DDU at the time. But this is a classic appearance for a GIST tumor, which is what it was. So it has this sort of central, often it has this central ulceration, and becomes quite anechoic in the center. Yes, so that's a GIST, a very large GIST tumor. That's the final diagnosis. All right, so finally, I'm just going to show you a couple of normal bowel. And, the more you look, the more you will see. So this is lovely normal anatomy where you can see your appendix being born from the cecum here with then the terminal ileum over the top. And that's really classic, where you've got the terminal ileum superficial to your appendix, and then your appendix sort of draping over. I'm going to just go back and have a look, and the appendix draping over that, the iliac vessels there. And you've got this psoas muscle deep to that. And then you can see how the overlying terminal ileum is sort of, you kind of get the picture that that's probably peristalsing itself, whereas the appendix is not. So once again, you can see that appendix, you can see it originating from the cecum there beautifully, and then you can see with a bit of eye of faith that the terminal ileum, I think in the next one we show you the terminal ileum going into the cecum, so the ileocecal junction, which is also really nice to see. So really, take your opportunities when you do. Here we go. That's when you can now see. So you can see where the appendix comes out. Oh, why are my clips stopping? It's having a little, it's very annoying. I'm going to try that one more time. You can actually see the appendix coming out, and then you can see the terminal ileum passing back in, which I think must be on my next one. Yeah, there we go. So there's the ileocecal junction right there, which is all very nice in someone who has very little subcutaneous tissue. So you get lovely image resolution. All right, that's it. So I'm going to stop sharing my screen and ask if there's any questions.
Great. Thank you so much, Elissa. That was amazing, and I think everyone will agree with me. Very, very useful in settings with limited resources where CT may not be available, or where not in places like Australia where patients don't really have to pay for CT if they've got Medicare. in places where CT may be too expensive to afford. I think bedside ultrasound would be very useful for these clinicians. Um,
Absolutely. And as I said, I think that a lot of this is not very, as long as there's so many resources out there that can help you, free resources that you can, Google what appearances, different things look like. And obviously there's, with Pearls, we've got the ability for image review sessions and things, which I hope to start being more involved in.
mm.